process in our door-to-needle improvement. And I stated earlier that I treated a greater number of patients with stroke mimics with IVTPA using our rapid response system without adverse outcomes. And adverse outcomes we would define as intracranial hemorrhage. And the question is that still good medicine? And that is a great question, because using IVTPA comes with a cost, and it's $2,000+ plus an admission to an ICU. And I would argue that it is, because if we believe the concept time is brain, and we understand that stroke does not come with a marker like a ST elevation on EKG or troponin, that we often have to make a clinical decision and diagnosis based upon best available information, and waiting an hour and waiting 2 hours or waiting till day number 1 to make a decision to treat is often way too late. So what we do is often we make quick decisions based upon the best available evidence, and sometimes we end up treating what we later find out with retrospect in time is that this does not turn out to be a stroke. We would all love that treatment rate to be 0 for a mimic. We do know, based upon data coming out of Dr. Grotta's institution, that these patients have an extremely low risk for intracranial hemorrhage, almost 0% in the literature. So we know it's safe. But what we do is, for every patient we treat who turns out not to have a discharge diagnosis of stroke, we look at it very carefully in a quality assurance fashion to determine were there signs and symptoms that led us down the wrong path. And often we find that, based upon what we knew at the time, we would not have altered our decision. But I agree, being more efficient, developing markers, whether those be imaging markers, and that brings up the whole question to see what about MR and what about CT perfusion, what about a CTA, to better select our patients, because we have to be doing better than just clinical exam, which is good, but it's imprecise. So I agree, that's a great question, and it drives home a very big point. Any comments?
This is how I do it, and I've got that young individual in front of me. I really don't know, is this a sort of a funky exam? Is it a stroke or isn't it? I ask myself, more likely than not, do I think this is a stroke? If I say to myself, more likely than not this is a stroke, I'll go ahead and treat the patient. If it's less likely, then I'll get an MRI scan and insist on a DWI abnormality. That's sort of the best way I know how to approach it.
All right, we'll finish up with 2 more questions. I'm going to answer a quick one here.